not uniform people. We have poor people, we have rich people, we have very thin malnourished patients, and we have very obese. So we have to pick and individualize our patients, their affordability. Some are very affordable; they don't bother, especially in the corporate setup. Most of them will say, okay, if it's a good drug, you give. The price is not an issue. So we have to individualize, and affordability is always we have to think. Whether the patient is going to take for longer or not. Initial 1 or 2 months they may accept, but later they may discontinue. We have to pick and choose the patients, and since it is uniformly priced, almost similarly priced, I have a tendency towards SGLT2 nowadays.
Sir, these gliptins are there in the market, I think, almost for about 8 to 10 years.
Yeah.
In your experience, after say continuous usage of gliptins, how many of them are ending up in failure of gliptins? Because I think they are the patients where we can try SGLT2 inhibitors.
Most of the patients. After 4-5 years of therapy, like any other antidiabetic drug, you have to keep introducing new class of antidiabetic drug, and finally we go to the insulin. So it's quite common for gliptins to lose their efficacy. The durability is limited.
So once there is gliptin failure, can we try SGLT2?
Not necessarily. You can start in place of gliptins also. You cannot wait for gliptins.
There is another group, took gliptins, again came back with HbA1c.
The advantage of this SGLT2 is you can start as a monotherapy also. You can start in the initial first few years. And even when the 20 years of diabetes, when you definitely know there is no beta cells, there is a complete beta cell failure, since it is insulin independent mechanism. Whereas gliptins are insulin dependent mechanism, since it is insulin independent mechanism, any phase of diabetic, any duration of diabetes, you can introduce this molecule and you will get the benefit. That is probably the gliptin has a disadvantage of beta cells not being there.
Thank you.